Alright, this is going to be the Levophed norepinephrine protocol, and this is going to be IMSA drug protocol 16HH. So, quick overview of pharmacodynamics. So, in this section we need to talk about alpha receptors and beta receptors. In Levophed, it stimulates alpha receptors in peripheral vasculature, producing vasoconstriction and an increase in systemic blood pressure. Now, whenever we talk about alpha receptors, we have multiple types. We have both alpha 1 and alpha 2. And alpha 2 kind of inhibits norepinephrine. Alpha 1 is kind of the gas on norepinephrine. So alpha 1 will cause primary vasoconstriction. In the actual vessels, and what this will do is this will bring up our systemic blood pressure. Now when we look at things as far as cardiac output equals stroke volume times the heart rate. Now in that stroke volume there's a couple more equations, one of those being peripheral vascular resistance and the amount of fluid that you have in the system. Both of those go into the equation whenever we're looking at the amount of stroke volume that the patient actually has, or the amount of blood that is ejected from the heart. Now this is definable by how much peripheral vascular resistance or tone the patient actually has, or the amount of fluid in the system. The heart rate factor comes into play. The faster the heart rate, the more ejection fraction it can be pumped per minute out into the system. Now what this medication does is it takes very large vessels and decreases them in size. Indications for this are going to be across multiple protocols. Dyspnea, more specifically in CHF, or cardiogenic shock, and this will be 3E. Post-arrest cardiogenic shock, and this is going to be 4J. ACS, chest pain with hypotension, 5C. Fever, septic shock, 9B. Dialysis-related issues, more specifically hypotension. And then just in general, primary indication in all of these is an adult blood pressure less than 100 millimeters of mercury systolic. And we are taking an assumption that this is secondary to cardiogenic shock, septic shock, or neurogenic shock. Now, in all three of these, we have blood pressure problems. Two of them, we are directly speaking to the problem specifically. And I'll give you an example here. In septic shock and neurogenic shock, these are types of distributive shocks. So there is a vascular bed problem. If the vessels are very large, you cannot maintain cardiac output due to inappropriate stroke volume. So what the medicine would do is speak directly to the alpha 1 receptor site and constrict the vessels down. Contraindications for this are going to be hypertension, and we would have no clinical indication if the patient was not hypotensive. So if their blood pressure is hypertensive in any form or fashion, we would not want to administer norepinephrine or Levophed. Side effects from this can be dizziness, headache, restlessness, tremors from the initiation or the stimulation of the adrenergic receptor sites. In respiratory, we can have difficulty breathing or dyspnea. The reason we have this is if we do not maintain a therapeutic level, and we squeeze down the vessels to the point to where it is posing a problem with the ejection fraction from the left ventricle, we can make them short of breath very, very quickly. Cardiovascular side, we can cause arrhythmias, bradycardia, chest pain, and hypertension. Genitourinary, decreased urinary output from the vascular squeezing, and renal failure. Local, we have to be sure that this thing has a patent IV. We can cause phlebitis at the site, or necrosis if it's in the tissues surrounding. As far as endocrine, hyperglycemia can occur. Fluids and electrolytes, we can cause them or easily put them into metabolic acidosis. That would be caused from decreased circulation at the peripheral tissues. This comes in a supply of 4 milligrams and 4 milliliters. And to mix our bag, we're going to actually mix it 2 mils of this into a 250 ml bag of dextrose 5% water. Now, how this works, if we haven't done a dilution in a while, I'm going to do a quick dilution on this. Our ideal dilution is going to be 8 mics per mil. So that's what our concentration strength is going to want to be. 8 mics per milliliter. And we know that we have a 250 ml bag. 250 times 8 is going to be 2,000. And we can check our work here really quick. The zeros easily cross off. 200 divided by 25 is 8. So that all works out to where if we mix 2,000 micrograms or 2 milligrams into a 250 ml bag, we're going to get a concentration strength of 8 mics per mil. That is also in the formulary of how to actually mix Levophed in the drug protocol. Dosage. Dosage range on this starts from 2 to 4 mics per minute, and we titrate it very therapeutically to a systolic blood pressure of 100 millimeters of mercury. We would start off with 2 and increase by 1 or 2. We could start off either by, here, let me kind of show you here. We could start either by 2 mics per minute or 4 mics per minute initially. But once we get it pretty close to 100, we probably want to increase it by just 1 until we maintain therapeutics on our patient. Now, the easiest way to do this is to do one of two methods. One, this sliding scale that they have in the protocol needs to be memorized. So this needs to be put to memory. That's one way to do it. Another way to do it is to figure the dose. How you would do that is a nice simple formula. Let's go back one slide. And this is going to give our answer in drops per minute. An example of this, let's say we wanted to start our patient off at 2. So the formula that we're going to need to remember on this is dose times the drip factor divided by the concentration strength per mil. Now we already have a constant on this. We already know what the concentration strength is because we just mixed it. It is in a concentration strength of 8 mics per mil. Our dose, 2. Our drip factor should be a 60 drop set. And this is going to be divided by 8. An example, 2 times 60 is 120. Divided by 8. 15 is our answer. We would have to do this formula every time that we wanted to go up incrementally. If we wanted to go to 3 times 60 being 180, divided by 8, 22, and so on. Special comments on this and special considerations that are in the protocol. 1, in the setting of any kind of tachydysrhythmia or tachycardic rate, induced cardiogenic shock, we should treat the tachycardia by specific protocol, not apply the hypotension protocol to this. If they are unstable, treat them accordingly to specific protocol. Examples of this would be things like SVT, VTAC. We should treat them per specific protocol. Ensure aggressive fluid resuscitation before we pull the trigger on Levophed, unless it's contraindicated. An example of a contraindication would be pulmonary edema. Be sure, number 2, that it is in a large vein or it is placed through the IO. If we cause or have extravasation of this medication, it will cause necrosis of the tissue from alpha-1 stimulus. The alpha-1 stimulus will constrict all the vessels in the site will become hypoxic, it will go into an anaerobic state of metabolism, and it will die from lack of oxygen. They do list an antidote for the extravasation of Levophed or norepinephrine. It is phentolamine, and the dosing that they give is going to be 10 to 15 mil saline solution containing about 5 to 10 milligrams of phentolamine. Now, phentolamine is an alpha-1 blocker, so what this would do is this would compete with the receptor sites to block that area and restore circulation. Avoid normal saline usage. We're going to mix this with dextrose 5% water. Normal saline promotes loss of potency through oxidation of the norepinephrine. So if we put it into normal saline, we're going to lose some of the potency of our actual drug. If you have any questions concerning this, please feel free to contact Chris Prutzman, prutzmanc@emsa.net, or 405-297-7244. Thank you.